Hello, my name is Dr. Toby Weingarten. I'm an anesthesiologist in the Department of Anesthesiology at Mayo Clinic on the Rochester, Minnesota campus. Our study will be published in Mayo Clinic Proceedings, January 2012 edition. Our study title is the Perioperative Emergency Response Team Utilization in a Large Tertiary Medical Center. The purpose of this study was to examine how the emergency response team was utilized in a group of patients that had recovered from anesthesia but were considered stable enough to be transferred to the ward for the first 48 hours. This study looked at a variety of patient and perioperative factors that could be associated with postoperative acute decompensation. At our institution, we have a rapid response team as well as a code team that can respond to acutely deteriorating patients on regular non-monitored wards to provide ICU cover care on regular wards. We have, as part of a quality improvement initiative, maintained a log of all such calls from June 1st, 2008 onwards. This study encompassed the time frame from June 1st, 2008 through December 31st, 2009. Patients included in this study included all patients that had a satisfactory anesthesia recovery in our post-anesthesia care unit and were deemed clinically stable enough to go to a regular postoperative ward and not require higher level of care which might be found in an intensive care unit. This study examined both patient characteristics such as demographics and organ-specific comorbid conditions as well as preoperative medication use, and procedural characteristics such as type of anesthesia, airway management, intraoperative events, and duration of anesthetics. We identified 181 patients that required a postoperative emergency response team call following dismissal from our anesthesia recovery unit. This is an incidence of approximately 0.2% or 2 per 1,000 anesthetic cases. In order to identify which of these clinical, patient, and surgical characteristics would be increase the likelihood of requiring an emergency response team call, we used a 2-to-1 matched case control design where we identified control patients who had a similar type of surgery and were matched within 10 years of age and by gender. Patients who had pre-existing central nervous system disorders such as dementia were more likely to require one of these calls. So were patients that used opioids chronically preoperatively, and in the intraoperative environment, we found patients who had signs of hypotension were more likely to have these calls. We deduced that these patients had hypotension not by looking at an absolute lowest blood pressure number, but by the use of a drug called a phenylephrine infusion to maintain blood pressure for the case and the total amount of intravenous fluid patients had. Patients who had phenylephrine infusions or patients who had more fluids than those that did not have ERTs were more likely to have ERT calls. When we looked at each of these three groups of patients, we found some interesting factors. One was that patients who had pre-existing central nervous system disorders were more likely to have an emergency response team call for changes in mental status. Patients who were on preoperative opioids were more proportionally likely to receive Narcan during an emergency response team than those that were not, and patients that had hypotension were more likely to receive fluid boluses during their emergency response team. When you looked at the overall indication for why patients were having emergency response team calls, the most common indication was hypotension, and the most common intervention was administration of fluids. The other two most common reasons were for cardiovascular instability, such as complaining of cardiac chest pain, or pulmonary problems such as hypoxia. Now, during these emergency response team calls, 6 would be classified as a regular code, where patients required cardiopulmonary resuscitation, reintubation, or similar interventions. 2 patients died during the emergency response team call, and 4 patients were taken to surgery. 39% of these patients did require transfer from a regular nursing ward to a higher level of care, such as an intensive care unit. The others were able to be treated on the regular ward. When we examined how these patients did compared to control patients, we found that in-house mortality and complications were greater in the patients that received an emergency response team call, and that their hospital length of stay was a day longer than the control patients. As anesthesiologists, we're oftentimes faced with dilemmas as to where to best triage patients after surgery and adequate anesthetic recovery. This study identified 3 factors that may help the anesthesiologist decide where best to triage their postoperative patients. We would like to think that our findings would help guide the anesthesiologist to easily identify patients that may acutely decompensate unexpectedly after surgery. It's unknown, though, if this was applied to clinical practice, that it would decrease overall emergency response team utilization rates. One area of research would be to determine if these easily identifiable patient and procedural risk factors could be used to better triage patients postoperatively and reduce overall emergency response team utilization rates in our institution. The take-home message is that patients tend to decompensate early after their surgery, even after a period of stability in the recovery room. It's important for the anesthesiologist to be aware that patients with central nervous system disorders, opioid use, and intraoperative hypotension, even after a stable recovery room stay, can decompensate early in the postoperative period. Such factors can allow for better triage of patients postoperatively.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.